Welcome to Module 1 of the Disability Inclusive Health Services Toolkit. Now that you have completed the activity in Step 1 and thought about why disability inclusion is important to your work, in this short presentation, we will explore why disability inclusion in health is so important for equity and necessary for achieving universal health coverage. Current estimates indicate that people with disability make up 15% of the world's population, and this number is growing. In the Western Pacific region, key contributors of disability include an ageing population, poor nutrition, an increasing prevalence of non-communicable diseases, road traffic accidents, natural disasters, environmental factors, and injuries from violence and conflict. For health service providers, this means that there will always be a proportion of your health service users or patients who have a disability, and that health services need to be prepared to meet the needs of this growing population. Ensuring that people with disability can access the healthcare services that they need is a big step towards achieving universal health coverage and the realisation of Sustainable Development Goal number 3, to ensure healthy lives and wellbeing for all. Many health programs, particularly those focused on disease prevention and health promotion, need high levels of participation across the population to be effective. Making sure that these programs are inclusive of people with disability, remembering that they are 15% of the population, has benefits for the health of the whole community, and making services more inclusive and accessible can have benefits for many people, not only people with disability. People with disability have the same or greater healthcare needs as everyone else. In addition to all the reasons already mentioned, healthcare must be inclusive of people with disability because they have the same general health needs as all people in the population across their life course. This means they need access to all aspects of healthcare, for example, childhood vaccinations, sexual and reproductive health services, prevention and treatment of disease, management of injuries, and palliative care, just like everyone else. However, people with disability may also need health services for reasons that are related more specifically to their disability or impairment that members of the population without disability may not require to the same degree. This may include things like rehabilitation services, nutrition support for people with difficulty eating, wound care for pressure sores, or even orthopaedic management of bony deformities or contractures. In addition, people with disability, depending on the nature of their disability, can be at greater risk of a range of secondary, comorbid, or age-related conditions that also require healthcare. Secondary conditions are physical or mental health conditions that may occur as a result of a primary condition, for example, pressure sores in people with spinal cord injury. Comorbid conditions are those that co-occur with another condition, for example, epilepsy co-occurring with autism. Despite having the same or greater need for healthcare, people with disability are more likely to experience worse health outcomes. For example, they are at higher risk of developing non-communicable diseases. But despite these needs, people with disability are more likely to have unmet healthcare needs and to experience exclusion from health services and health promotion activities. For example, women with disability are less likely to receive cervical cancer screening services. Adolescents with disability are less likely to be included in sexual and reproductive health programs. People with intellectual impairment are less likely to access routine health checks or have their chronic health conditions monitored. Across all countries, including low, middle, and high income countries, it is well known that people with disability face significant barriers that prevent them from accessing health services. Often the difficulties they face are not about their disability specifically, but a reflection of wider attitudes and prejudices toward people with disability in the community, or limited legal protections and a lack of attention that has been given to disability inclusion in the past. Barriers faced by people with disability can affect both their demand for health services or health-seeking behaviours and the supply of health services, including health information by health providers. We think about the major barriers to health for people with disability as falling into 4 main groups. First are attitudinal barriers. These include stigma and discrimination toward people with disability, a lack of knowledge or training of health workers, a lack of inclusive policies in the health system, and a lack of inclusion of people with disability in the health service planning. Secondly are physical barriers, which are perhaps the ones most people think of. These include the location of health services, an absence of accessible transport options to get to health services, poor access into health facility buildings due to stairs or other obstacles, and a lack of accessible toilets or furniture in consulting rooms. Third are communication barriers. These prevent people from having access to health information and include a lack of alternative formats of communication, such as sign language interpreters or use of visual supports, using jargon that people cannot understand, or poor signage in health facilities. And the fourth group of barriers are financial barriers, and these include both the direct and indirect costs associated with seeking and receiving healthcare, for which many people with disability find catastrophic. In modules 2 to 4 of the toolkit, we will go into further detail about these barriers and begin to discuss some simple strategies to overcome them. This flowchart, which is also on page 11 of the toolkit manual and is used in an activity in step 6 of this training module, shows us the many steps that a person goes through when accessing healthcare. People with disability may face barriers at any stage of this journey. For example, are they aware of the health service? Are they willing to access health services based on their past experiences? Are they able to leave their house by themselves, or do they need a support person? Can they afford the health service and the transport to get there? How do they get there? Is transport accessible and available? Is the entrance to the health service accessible? Is it clearly signed? Are staff at the entrance friendly and welcoming towards them? Once inside, is the reception area accessible? Does the health information system include data on disability so that we can monitor if people with disability are getting healthcare? During the appointment, is the health worker responsive to the person's needs? Do they communicate in a way the person can understand? Are the examination tables accessible? And after the appointment, how are future appointments made or follow-up information communicated? Can the person with disability access this information? Have they been referred to any appropriate specialist services? As you can imagine, there are potential barriers to health at all points along this journey for people with disability, which we need to be mindful of. The aim of this training and of the Disability Inclusive Health Services Toolkit is to work towards removing these barriers so that people with disability can receive the healthcare they need on an equal basis with all people. Now that you have a good understanding of why it is so important that we are inclusive of people with disability in healthcare and some of the barriers they face, please complete the activity in step 3 of the workbook.